So I'll do my best. Thank you, Chairman, for that kind introduction. I think I'm as confused as everybody else, being an Irishman based in Canada, representing the ESICM at a meeting in Dublin. But so biomarkers for ARDS. I have two conflicts of interest. They're not relevant to this talk, but I have academic collaborations with two companies looking at stem cell therapies. So the Berlin definition, as Professor Antonelli very eloquently showed us, is the best we have right now. It's a definition based on acute onset, hypoxia, lung permeability or lung water, and abnormalities on the chest X-ray. And unfortunately, we don't have a definitive test. It would be really great to have a test that just told us if patients had ARDS, but we're not there. As also mentioned by Professor Antonelli, we know that the hallmark of ARDS is diffuse alveolar damage, so that should kind of be our benchmark when we're trying to work out a criteria for diagnosis. And he also showed you this study, which means I can breeze through it, which is the study from the Esteban group, where they looked at autopsies. Now, a couple of things to remember about when you look at an autopsy study is that the patients died, and only 40% of our patients die of ARDS. So, and that's reflected in the fact that the distribution of mild, moderate, and severe is quite different to what we see in the clinical setting, in that these are predominantly severe patients. And as he showed you, only 12% of mild ARDS patients had evidence of diffuse alveolar damage at autopsy, and that improved up to 58% with severe ARDS. But clearly, there's a large chunk of patients that don't have the classic criteria when they go to autopsy. And so what we kind of have is we have a bunch of patients that have acute respiratory failure. Some of them have ARDS, and some of them don't. And that's a true fact if we could determine it. And then we have a set of criteria that help us to parse out that group that have ARDS. And where exactly you put this circle is a matter of debate, but clearly there are some patients who are in this category who don't have ARDS, and there are some patients outside this category who do have ARDS. And this is a problem. And as Dr. Jonn Boylan and his colleagues very eloquently showed when they looked at the data from the Esteban group, the previous criteria, the AECC criteria, or the current Berlin criteria, really don't do much better than the toss of a coin in terms of telling you whether or not you're going to die with ARDS. So this is the AECC criteria. The line in green is basically the line of neutrality, and it only barely makes it above the line for either the AECC criteria or the Berlin criteria. So might biomarkers help? Well, they might help in a number of ways, but first I suppose I should define what I'm talking about. And it's basically anything that can be objectively measured and evaluated as part of a normal biologic process that gives us an insight into the disease process. And going back to ARDS, I'm going to focus on plasma measured biomarkers. So you can actually look at lung compliance and consider that to be a biomarker. And as we saw when the group who came up with the Berlin definition, they actually looked at a number of different physiological biomarkers but found none of them to really make the grade, and so they didn't include them. But if you're looking for a biomarker in the plasma, what you want to get is something that happens as a result of the injury process, but that's pretty specific to the lung. So it needs to be something either from the lung epithelium that shows injury there, something from the lung endothelium, or something that reflects the inflammatory process that's going on. And in terms of the potential of biomarkers, there's a few things that they may help us with. So they may help us to get a better precision around the diagnosis of ARDS. They may help us to recognize ARDS. As I say, it'd be really great to just have a blood sample that you could draw and come back, and if it's over a certain level, that's it, they've got ARDS. It might help us to predict ARDS in at-risk populations, which would be very handy because we might be able to do things to reduce the risk of them getting ARDS. And it would be really nice if the biomarker could tell us something about the pathogenesis. So not just be a marker, but actually be part of the pathological process. It would help potentially with risk stratification. And it may help us to sort of try to split ARDS into different subgroups that we might do different things with in terms of trying to manage them. And in terms of enhancing the precision of the diagnosis, of course, what we would like is something we could add to our armamentarium that would put the criteria and the patients with ARDS much more closely matched together. So we would know that we were treating and managing patients who truly had ARDS. And in terms of enhancing recognition, the reason it's useful is that it might allow us to implement evidence-based strategies to reduce lung injury in patients at risk. And this has been shown to be useful. We could target protective ventilation, our fluid restriction, neuromuscular blockade, and prone positioning on patients who truly have ARDS. And we do know from studies like the LungSafe study that we underutilize these therapies. And that's probably in part because we under-recognize ARDS. And in terms of the data from the LungSafe study, it's pretty clear that we under-recognize it. So if you look at ARDS on day 1, we only recognize 25% of patients with mild ARDS. That goes up to just over 50% at any point in the disease process. And this improves. We're better at diagnosing more severe ARDS, and that makes logical sense. And it goes as high as 78% with severe ARDS. But that still means quite a lot of patients are not recognized. So it would be very useful to have a test that would help with that. In terms of predicting ARDS, well, what's the point of trying to predict ARDS? The patients are in the ICU already, or they've had a high-risk procedure, so you know that they're at risk. Well, it may help us to target interventions, especially interventions that have side effects. So if you have an intervention that might help but has a side effect, you would feel much more comfortable targeting it at the group that are at more risk. And it would allow us to implement bundles of strategies to prevent ARDS in that population, such as optimizing mechanical ventilation, aggressive resuscitation, reducing transfusion. And we know that this works. And we know that from the very nice study from the Mayo Clinic, where they implemented this bundle in all their patients in the ICU who were ventilated and at risk for ARDS. And they showed that they were able to reduce dramatically the number of patients that developed ARDS after admission to the ICU. And so if we could predict those patients with a bit more precision, that would be really helpful. And it would be useful in terms of prognosticating outcome in ARDS. So if we could understand the factors that contribute to poor outcome, we could focus our high complexity interventions on those patients. So you might decide that these patients need the higher complexity, more expensive therapies earlier because they're at higher risk of dying. But of course, when it comes to prognosticating outcome, any biomarker, any other process that we come up with needs to do better than the standard gestalt that we all have at the end of the bed. And I'm always reminded of the epitaph of Spike Milligan. So Spike Milligan was a British comedian of Irish heritage with a very wicked sense of humour. But he had put on his headstone a phrase which is in Gaelic. And it's in Gaelic because in the churchyard they didn't want it in English because they thought it might upset people. But what it says is, Dúirt mé leat go raibh mé brocha, which means, I told you I was sick. So, if I come back to you with your ARDS patient and I tell you, oh, the TNF is high, I think this guy is sick, I think you'll tell me that you already knew that. So you need a biomarker that does better than that. So what are the promising biomarkers? Well, I'm not going to go through a huge encyclopedic list, but there are candidates for each of the major areas. So the lung epithelium, people have looked at surfactants, they've looked at soluble RAGE, they've looked at KL16. The inflammatory response, the usual suspects like TNF, IL-6 and IL-8 have been well studied. The lung endothelium, things like von Willebrand factor and Ang2 are well studied. And as I said, there are other biomarkers that I won't go into, like genetic markers of genetic predisposition. And of course, like lung compliance could be used as a biomarker. What would we need from a biomarker? Well, we'd need something that's easily, cheaply, quickly, and reliably measured. And ideally measured somewhere near the bedside so that you can get it on a Friday evening if that's when you need it. And it would be good if it was related to the pathogenesis, because then it would also be a potential therapeutic target. It needs to be fairly low in terms of its invasivity. If it needs a lung biopsy, it's probably not going to make it as a biomarker. And it needs a pretty high sensitivity and specificity. And it would need to provide information around diagnosis and classification. and prognosis. And this is one of the problems. Sometimes I think we aim too high and that we want one thing to diagnose and prognosticate, where maybe we need different things for different stages of the disease. And this is a meta-analysis, and they looked at all the different biomarkers. But what was interesting about this meta-analysis is they found different biomarkers were important for different things. So they looked here at soluble RAGE, which is a lung epithelial marker of injury, and von Willebrand factor, which is an endothelial factor, and found that both of those helped in predicting the diagnosis of ARDS. But when they looked at prediction of outcome from ARDS, what they found it was the inflammatory markers. So there was the initial injury helped with the diagnosis, but what drove poor outcome was ongoing inflammation. So they found that IL-1 beta in this particular analysis was the most useful for predicting outcome. And this is an interesting biomarker. I'm not going to go through every possible biomarker, but I wanted to mention this one. It's angiopoietin-2, and angiopoietin-2 is from a family of vascular growth factors, and it actually inhibits the effect of angiopoietin-1, which has a protective barrier effect. So it's not just a biomarker, it may actually be part of the chain of events that leads to permeability leak. And this is work from Carolyn Calfee in UCSF. And what they did, they looked at Ang2 in patients in the emergency department and who were at risk for lung injury. And what they showed was the patients who went on to develop an acute lung injury had a higher Ang2 concentration compared to those who did not. And so they were able to use that in helping to predict the onset of acute lung injury. Lorraine Ware, who's also done a lot of work on this, and this is a study that both Lorraine and Carolyn were involved in, they looked at phenotyping, so this idea of indirect versus direct ARDS. And what they showed was that the biomarker characteristics were different. So if it was indirect ARDS, what you tended to see was lower levels of lung epithelial injuries, where you saw higher levels of lung endothelial injury. And you saw the opposite then if it was a primary ARDS or a lung-derived ARDS. So why aren't we using biomarkers? Don't they seem like they're pretty cool things to be using, and we could all pretend we're cardiologists and just get our biomarker levels? Well, the problem is that we don't have a good biomarker. These were the list of things I put on earlier about what a biomarker needed to be. But in terms of, we don't have anything that's easily or cheaply or quickly available, and we certainly don't have anything with high sensitivity or specificity. And the specificity and sensitivity stuff is hard to wrap your head around, but basically we need our test to tell us the true positives and the true negatives, and we need not to have too many false positives or false negatives. And this is where the difficulty is. So if I bring you back to the Ang2 paper, we have to define a cutoff here and decide everything above the cutoff is ARDS and everything below the cutoff is not. So we could put it here. If we do that, then we're going to miss half of the patients who had acute lung injury, but we don't have many of the ones who didn't have lung injury. If we put it here, we get almost all the patients who went on to have lung injury, but there's a whole pile of patients here who didn't have lung injury. And when you look at that mathematically, and the problem again is exacerbated by the fact that these are not even groups. You actually have more who don't develop lung injury. So when you look at that, what you want actually to know is when you have a positive test, does this patient have lung injury? Are they going to get lung injury, this particular patient? So what you want to know is the true positives over all the positives. And when you do that for this test, I'll just bring you to this one, what you have is a positive predictive value of 0.2. So that means I have a test that's going to tell me that 1 in 5 of these patients with a positive test is going to go on to develop acute lung injury. You probably knew that already with the patients. So what is the future for biomarkers? Well, I think the future for biomarkers is integrating it with our current knowledge level. They won't be sufficient on their own. And this is an example where they took the Ang2 data and then included it with the LIPS-2 prediction score and found that the area under the ROC curve, which is the sensitivity specificity trade-off curve, was enhanced by having the two together. So we're going to use these, but we're going to use what we already know. And this is an analysis done from the ARDS ARMA study and the alveoli studies, where they looked at modeling outcome. And they looked at clinical predictors, and they looked at a raft of biomarkers. And what they showed was that the biomarkers on their own did not actually perform as well as the clinical predictors. But when you put them together, they performed best. And then they did a reduced model where they just put in the key ones and found that they got a pretty good trade-off. So just 4 things, Apache 3, which we generally have data on, age, surfactant D, and IL-8, was a good group to put together. Lastly, I want to talk a little bit about this study, which is a very interesting study done, again, by Carl and Calfee, where they took, again, the data from the ARMA, the tidal volume, and the alveoli trial, and they had a large data set on them, on these patients with clinical data and also things like IL-8 and IL-6, von Willebrand factor, the kind of things we've talked about already. And they put them all together, and they found that there were 2 separate, what they called endotypes, or basically they were able to partition the patients into 2 groups. So phenotype 1 was this blue group, and phenotype 2 is this red group. And they're just looking at the difference in each variable between the groups. And phenotype 2 is a kind of a hyperinflammatory, high IL-8, high IL-6, low in things like protein C, low in bicarbonate, which is what you'd expect. So they are about a quarter of the patients. And what they showed in terms of mortality was there was a mortality difference. So if you were a phenotype 2, the hyperinflammatory phenotype, you had a higher mortality. And interestingly, when they looked at PEEP, they showed that the effects of PEEP in these 2 subtypes were different. So if you looked at PEEP in phenotype 1, the lower hypoinflammatory group, there was actually a mortality in the low PEEP was lower than in the high PEEP group, whereas in the phenotype 2, mortality was improved with PEEP, with high PEEP. Now, I'm not suggesting for a second that you go and measure 40 different things to decide how to set PEEP just before Dr. Gattinoni gives out to me. But it's an interesting kind of proof that you can get additional information from the biomarkers. So in summary, I think biomarkers have promise. We're clearly not there yet, but they may be useful in terms of predicting ARDS, they may help in terms of diagnosis, and they may help in terms of prognostication and response to therapy. But it's likely that no single biomarker is going to do all this. And in fact, no one biomarker will do any one of these things. And we'll be looking at combinations, and we'll be looking at incorporating it into the data and the information that we already have. And that's going to be where these are going to have effect. But I think they may play a key role in determining these ARDS phenotypes, which we've not really been able to do on the basis of the obvious clinical characteristics so far. And I think these would likely be used to guide future clinical trials. Thank you.